Welcome back. After reviewing the earlier videos, we realized that we haven't dedicated enough attention to the subcomponents of a PSA test and their role in refining disease diagnosis and reducing overtreatment. As such, our focus today will be exploring the subcomponents of a PSA test, PSA density, PSA velocity, free PSA and the prostate health index, and their application in individualizing the diagnosis and risk assessment. By the end of this module, you should be equipped to initiate discussions with your surgeons about disease diagnosis and risk assessment. PSA density is calculated by dividing your PSA level by the size of your prostate. A high PSA density suggests that a relatively small volume of prostate tissue is producing a lot of PSA, and vice versa. In some instances, men with normal or low absolute PSA levels have been found to have prostate cancer. Conversely, some men with very high absolute PSA levels don't have prostate cancer, instead, may have benign conditions such as BPH. Uro-oncologists use PSA density to help differentiate malignant diseases from BPH, particularly when the overall PSA score ranges from 2.5 to 20. Several clinical publications have found a statistically significant difference in PSA density between men with a positive biopsy and those with a negative one. When the PSA level is between 2.5 to 10, a PSA density greater than 0.25 indicates a 46% higher likelihood of cancer. Furthermore, a PSA density of 0.3, when the PSA level is above 10, shows a 79% chance of a malignant diagnosis. The PSA density threshold for patients diagnosed with some stage of cancer is between 0.13 and 0.18, depending on the source. PSA velocity is given year-over-year growth and represents an estimate of future PSA levels. For instance, a patient with a current PSA of 2 and a PSA velocity of 0.5 would be projected to have a PSA of 2.5 nanograms/ml in 12 months. Debate within uro-oncology circles. Advocates argue that PSA velocity is a better predictor of treatment, recovery, and mortality than the total PSA level. For instance, men with a PSA increase of 0.75 within a year show a high risk for prostate cancer. However, an equal number of studies argue that PSA velocity and doubling time have no bearing on the risk of aggressive disease. Another key factor to consider when determining the malignancy of a prostate tumor is free PSA. Free PSA refers to the amount of PSA in the blood that is not attached to other proteins. It is usually represented as a percentage. Lower free PSA levels are of higher concern. Patients with free PSA below 10% should immediately get a biopsy, while a man with a PSA score of 4 to 10 and free PSA between 10 to 25% should be biopsied to ascertain malignancy. A low PSA level combined with a low free PSA level might indicate prostate-related issues and necessitates further evaluation. Free PSA, PSA density, and PSA doubling time are supplementary data points that can enhance the treatment algorithm, refining patient risk assessment for prostate cancer and potentially reducing unnecessary biopsies. Over the past decade, PSA isoforms have been identified, increasing the specificity for prostate cancer. Notably, the 3-form of PROPSA, which has become commercially available, offers improved performance over total or free PSA in detecting prostate cancer on biopsy. Ultimately, a higher P2SA offers a higher sensitivity than free PSA, PSA density, and total PSA. The Prostate Health Index or NBSP, PHI is calculated using the formula, -2 PROPSA divided by free PSA, multiplied by the square root of the total PSA. Consequently, men with higher total PSA and P2SA, along with lower free PSA, are more likely to have clinically significant prostate cancer. The higher the score, the greater the probability of diagnosing clinically significant disease upon biopsy. A PHI range between 0 and 26.9 corresponds to an approximately 10% cancer probability, while a PHI score over 55 corresponds to a 50% chance. Numerous global studies have shown that PHI outperforms its individual components in predicting overall and high-grade prostate cancer on biopsy. Moreover, PHI also forecasts the likelihood of disease progression during active surveillance, offering another non-invasive. As you can observe, assessing a patient's risk of prostate cancer is multifaceted, with numerous inputs, formulas, or algorithms involved to ascertain disease aggressiveness. The following guidelines are recognized by urologists, so it's critical to understand them and their applications. A gray zone PSA of 2.5 to 10 and a PSA density of 0.25. or PSA greater than 10 and PSA density 0.3 or higher, indicates cause for concern. PSA velocity measures the rate of PSA score growth over a specific time frame. Despite controversy, many urologists use this metric to assess disease aggressiveness and mortality. A PSA velocity of 0.75 or greater within 1 year requires further investigation. Free PSA quantifies the amount of unattached PSA in the bloodstream. The lower the result, the higher the concern. A free PSA less than 10% and or free PSA of 10% to 25% with a PSA level between 4 and 10 should raise alarm. PHI uses subcomponents of the PSA free PSA, total PSA, and 2-PROPSA to risk stratify the disease. It's an emerging scale rapidly gaining acceptance. When the PHI score reaches 26.9 or greater, the patient should undergo a biopsy. Every year, John Wooden would instruct his team on how to properly lace and tie Theor shoes. It seemed simple and overkill on the surface, but Coach Wooden always had a purpose and method to the madness. He knew that the feet were a ball player's foundation. If the feet didn't function,